नहीं. Guys, hello. So as promised, we have come live. Now see, this is what is important for all of us to notice. Yeah, she has a posterior nodule here. Okay, and as I mentioned, clear cut ultrasound by Vismay has demonstrated a brilliant triple bowel nodule. In fact, excellent diagnosis of the deep parametrial endometriosis also. And for all of you who are even slightly interested, okay, you can go through Vismay's sessions on how to diagnose it on ultrasound. So this is part 1 of the nodule which comes out. Now guys, see, remember, this is where the nodularity has really kicked in here. Okay, so when the nodularity kicks in like this, that part is basically refusing to move also. Alright, that part has simply no movement associated with its location. That is how you know how hard it has gone and affected the tissue. So what are we supposed to do? Just grasp on it. It's going very, very low down. Here we go. See that? Very low down. And we just resect. I will show you that when you want to dissect here, okay, you got to be careful of the venous system. Let me just verify from Santoshi if everything is live. It has she has told that yes, it is going good. So no problem, guys. Here we go. This is that nodularity which is so bad, which has gone here. This space is normal. You can see how my instrument enters in that space. Now ideally, as I have told many times, and I am telling again, for people who are not adept with this type of skill set, okay, switching to robotic surgery or robotic platforms at this level. See that? Can you see the nodule? Can you see that endometriotic leakage from there? Yeah. Switching to robotics here is going to make a difference. It's going to help you, right? But if you are an ordinary Indian citizen like me, laparoscopy should be good enough for you. So here we go. Good amount of separation has already occurred. You will see how the pull through. Please gas को leak करने से बंद करो. So before I actually proceed, this entire live is being brought to you by Arun, and you all met him at the Project Pelvis conference. He is a wonderful little boy, very hardworking. Okay, and he is working extremely hard in order to make sure that this demonstration occurs to all of you. Yeah, our anesthetist is obviously Dr. Arun Agarwal. You all, I mean, there is nobody who doesn't know him. And Arun sir, hi. Arun sir, yes, he's saying. So this is where the vagina will open, friends. I'm trying my best to not actually open it and just go close to it. Here, see, I'm trying my level best, but it may open. Okay, of course, even if the vagina opens, there is no problem. There is no problem. This is the vagina. This is the vagina. Just to show everyone, see that. That is the vagina. So I'm just dissecting. We've gone pretty deep there. Just to give a heads up to everybody, to just show you how deep we are operating. Basically, Santoshi, all clear? Yes or no? Suction, please. Arun sir, hi. Hi.
Hi.
Can we have Arun sir on the frame, guys? We want the charming Dr. Arun Agarwal.
Yeah, why not?
Yeah, that's a good one. Yeah. Okay. So, Arun sir, just a question to you. Basically, thank you first of all for, doing all these cases with us, because people, you should often understand and realize, we as surgeons can only do cases or such type of cases. Okay, let me just put it that way. When we have people like Arun sir with us, who are willing to give and willing to handle every situation which arises in all these patients. Yeah. So Arun sir, a big thank you. You of course know how much we all love you. But then coming to the question, sir, any specific anesthesia things you get into when we are operating such level of complicated procedures from your end?
Okay, so first of all, the thing is because of the long duration of these surgeries,
Yeah,
we have to maintain a steep head low position for a little longer time.
correct.
So that one thing that we have to take into consideration. Um,
Apologies, Arun sir, I'm just cutting you here.
yeah.
Guys, this is where that nodule is just about to come out. You can see that. The whole thing, okay? That is the vagina. As I told you, I will try my level best to preserve it. Yeah, absolute level best to preserve it. That is the levator ani muscle there. Yeah, Arun, the good thing with Arun sir is that we have worked together in so many cases that now when I am getting stuck in anatomy, I can straight ask Arun sir क्या लगता है? And usually his knowledge of predictive anatomy after doing so many endometriosis cases has become as good as everybody else. So it's a big boon. But yeah, sir, you were saying something and you can continue now.
Okay, so basically, such gross deep endometriosis
Yeah,
definitely requires a lot of time for surgeries.
correct.
So we need to maintain steep head low position for a long duration of time.
Right,
So we have to take that into consideration. The hemodynamics, the respiratory parameters, the airway pressures,
right,
and if the need arises, then maybe I will stop you for some time and
correct.
give a neutral position, for some
Yeah,
time,
yeah,
and
yeah.
then again restart with the steep head low position
Yeah.
and change my ventilator parameters.
Yeah. Sir, I've seen that many times when when we are doing these ones, like the ones which we are doing today, this triple bowel nodule and all, you have never questioned sort of you have never asked me a question that yaar kitna time lagega, how much time it will take, and also is there any preset parameters which you follow, which probably you would want to tell to our fellow anesthetists who must be watching in?
Okay, so what basically what things that I keep in my mind is I consider all this your deep endometriosis, long duration surgeries.
Yeah.
I treat them like the robotic surgeries,
Right.
wherein once the robot is docked, you can't move the patient, you can't change the position, and you have to maintain the same position throughout the surgery.
Right.
So what precautions I would be taking in robotic surgeries, those are the precautions that I take in these surgeries as
Right.
well.
Right.
So I never interfere with surgeons' field. I mean, I let them operate the way they want, take as much time as they want.
Great. Sir, anything about the post-operative pain as far as these girls are concerned?
Okay, so what generally I follow is multimodal analgesia.
Correct. Could you? I wanted you to speak a little bit on that. So if you could be, if you could mention some details of that, sir.
Yeah, so basically what the principle of multimodal analgesia is, like say different tissues in body has different type of pain receptors. So just giving one, it's not like one thing that would suit everybody. So I give mixture of NSAIDs, opioids, uh, paracetamol, maybe regional anesthesia also. So basically all the muscles and the internal tissues, skin, all different type of pain areas are taken care of.
Correct.
So that's what the principle of multimodal analgesia is. Of course, if the drugs, any particular drug is contraindicated, then we modify the recipe.
Right.
Like for this patient, she is allergic to paracetamol, which is very unlikely. So because of that, I would be avoiding paracetamol for this patient, and I would switch over to tramadol or maybe some other analgesic if required.
Okay. That was, I think, a great point because, friends, just I wanted to show you. Look at the lumen here. Can you see the lumen? See how large it is. Compared to that, just look at the strictures now, one by one. This is number 1, this is number 2, and that is number 3. So we have 3 places which are so badly strictured, okay, that no wonder, absolutely no wonder the lady is in a situation what she is in. So care must be taken, and proper, you need to make sure about your stuff in life, that in cases like this, no playing around with the patient. Do not offer them anything which does not give them any sort of, don't give hope based therapies. They will definitely change the doctor because the pain in all these things is a bit too much. So, but of course, just go by that logic. Yeah, so here we go. I'm just dissecting it out. I will be dissecting it out even down. Arun sir, many a times our fellow anesthesia colleagues may have a little bit of inhibition to providing very steep head lows. I know you don't have that inhibition, I know that, but I would just want you to have maybe a thought process as to like what goes in the mind of an anesthetist. Why do they not allow a head low? Many people would complain, right, that are head low nahi mil raha, head low nahi mil raha.
I know that.
Yeah, so that's my reason for asking you.
Giving any such steep positions, they have their own cons.
Okay.
So like giving
what would be the cons which you would say that array, you know, I don't give a steep head low because of this, aisa kuch?
No, I would avoid giving steep head low position in certain valvular heart diseases, wherein I would be little more careful. In very obese patients, of course, I do give steep head low even in obese patients.
Right.
But in those cases, then I switch over to pressure control ventilation.
Okay.
And definitely giving steep head low for a long duration of time definitely increases some amount of intracranial pressure.
Acha.
So yeah.
How much is that time for that, sir?
That too, I mean, to
Is
say that literally,
any such guideline?
No,
I mean,
I am not aware of any such guidelines about that. But yeah, definitely it would increase some amount of intracranial pressure. So I tend to take little care for that also.
Superb. No, it's very interesting for people to sort of know and learn this, because friends, remember, these are some of the, I would say these are very high-end gynac surgeries, isn't it, Arun sir?
Yeah, definitely.
As far as gynac surgeries are concerned. But it's okay. So that's detached. I'm happy. Now if I just go down from here, I will just see this, you know, the lesion is going right till down there. So it's a very deep lesion extending in that depth. Now whenever a lesion is so low down as well, triple bowel nodule, often just remember, we have counseled her about everything as far as such a massive bowel resection is concerned. Expect some amount of, you know, short bowel syndrome or something like that, Lars, you know, which happens to happen in a situation like this, because this is just too low down. Here, see that? Here is where we actually need to be careful here, because she had invasion in this plane. So she had invasion here, and here is where we actually need to be very careful, because remember, there is a nodule just above this. Can you see that? There is a stricture just above that. There is a stricture just above that. So when you enter this plane, be careful, because the bowel will now become very narrow. See that? Can you see? See how small that bowel has become? See? Just there. See? So be very careful, huh? Double, triple strictures like this. Here we go. It's becoming good. You know, that part of the bowel is where we need to be focused on. So here we go. I'll be making an incision here to push this part of the segment of bowel below. See that? Very gently, because that incision is going to allow us to apply our staples in that plane and application of staples is something which is going to be very important. The reason why I'm saying this is because I'm planning to do a transanal excision, and whenever we want to do a transanal excision in a situation like this, we got to be like super good as to where we are going to be opening it up, because I want to preserve all of this. See this? I want to preserve this. I want to preserve all of this. If I preserve this nice and clean, I'm giving the patient a great. It's a very thinned out bowel, by the way. Yeah, it's just this much. Okay. So, usually what we are going to do is actually going to be very simple from here on. See that we have dissected there, which is where our incision is going to be. I would still like to go above that plane, and I would just like to incise slightly above that plane, just a little above. 31 number anvil. इसमें यहाँ पकड़, धीरे धीरे धीरे. There we go. See that? Beautiful dissection done till that level. Everything gone down. Nice and clean. No extra garbage tension on that bowel. We don't want that. Correct. That is good. This is where the stricture is, guys. That is the secondary stricture. पहले एक रेक्टल प्रोब डाल दो अंदर. So I would just like to do this in this case, a rectal probe based primary assessment here. Yeah, डालो. आ जाओ. बस. Keep it there. So see this. Based on this assessment, you can see this nodule here. So based on this assessment, one thing is pretty clear. Yeah, is that छोड़ दे uterus ने. You can gently separate out the fat from here. See this? Gentle separation of the fat. Very gentle. Just defat this a little. This is where I would actually want my anvil to come out here, because this is where that nodularity is. Okay, can you see that little bleeder which started popping from there? I'll just coagulate it. Gentle, huh? Very gentle in this plane. I think I am good to go transanally now for me to cut here and then to pass it down from above. So I'll just do one thing. ऐसे ही रखो, transfer stapler दे दो ऊपर. Should be good now. We should be able to knock it out transanally. I will go above with a 12 millimeter trocar, and I will come inside with a 60 millimeter ring for a transfer stapler. So can we have the transfer stapler to be shown on the front cam, guys? This is the front cam, and this is how the transverse stapler is. Just see that. That's how it opens. If you are a gynecologist trying to follow this, you can just close it and you need to put it inside. Once you put it inside through this, be very gentle inside. Instrument please. You got to be very gentle and very nice inside to the bowel. Just go to the lesion. So this is where the lesion is, guys. Very clearly you can identify the lesion in front of you, and the way in which we have done the dissection. See that the staple comes out from the opposite side. Can you see that? You can see it's coming out from the opposite side, and we have sort of taken a nice full thickness bite there. See this, a full thickness bite has been established. Okay, now once you establish a full thickness bite like this, that is when you actually fire the stapler. You can see the firing being done. Got to hold on, of course, for a little while, for around 10 seconds. When you hold on for 10 seconds, it is good, right? It's very good for you. Yeah, done? Okay, thank you. 10 seconds are over and we just cut. Okay, Now you can see here, you can watch here, as I told you, the lumen above na is very 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 big. Scissors de do. So I don't want to do much, I just want to cut through this, just want to keep that little part intact, because you know from there ye de do, any which ways that region is going to become a part of our anvil, you know, which we will put through this. We have multiple techniques of putting the anvil also, huh guys? So I'll show you 2-3 techniques, not 2-3 techniques, I'll show you one of the techniques today. You have multiple techniques to put your anvil inside, no problem at all. So now idhar aa jao. So now we have an option here, can you see this? See, now this region can be included as a part of my transfer stapling, okay, and this is where the stricture is. Here is the stricture, I can easily see the stricture, I can feel the stricture, because it is such a hard little stricture. 31 pass karo niche. So I will be cutting right here. When I cut right here, see that the bowel has opened up, and let निकाल दो उसको. Let him actually come in with the एक second, suction. Obviously the remnant stool which is present inside will pop out. You have another technique as well, right? You can actually block it off. Come अंदर आ जाओ धीरे से, या आ जाओ, yeah, good, it's done, it's clean. Come, open कर लो. You can change this suction now. So you can block कर लो. So it has come out nicely. But the gas is gone. Okay. So when the gas goes away, छोड़ दो. Come. The gas is back. Camera clean कर लो please. Can we clean the camera please? Can I have one more transverse? Can I have one more this thing? Alice? Camera not barabar. Come Vismay. Okay, so now nothing much needs to be done. थोड़ा सा अंदर आ जा, थोड़ा सा, बस, thank you. थोड़ा सा और, okay. Okay, I needed an Alice here. Alice दे दो एक, thank you. So we have two Alice. ओके नीचे खींच लो. ओके छोड़ दो, एक काम करो, छोड़ दो इसको. It's got put inside and finally it will come out now. Suction please. So you have two options, as I mentioned. See that? That is the window which I would simply want to obliterate and cut. Now I have an option here in this window. Can you see this? I just want to show this to all of you. I have an option here in this window. Can you see this? I have an option that I immediately put a transverse underneath here, underneath this, and I do something about it, but I won't be doing it. I don't do it that way. I'll tell you why, because I want to extract out the specimen off. Okay? So here we go. Come, sponge holder. Alright, thank you. So that's a huge part of the bowel there. If you can see that, all the two big strictures are lying down right there in front of you. So through the anus, we'll push the sponge holder. And we have grasped the, but it's not been grasped because it is so hard. That region is so hard. I mean, it's like a stone there, but I've still grasped it off, and the whole segment has gone out, which is a great thing, which is so important for us. Okay, now these small ones are going to be coming out through the 12 millimeter region any which ways. Okay, this anvil is I am going to be plastering above. Okay, suction inside. Here we have the bowel which we want to staple off, including, see this, here we have that region of the bowel which I will want to staple off now. That's the lumen. Now we have a technique to either close this lumen and staple off, or it's completely okay if you do not close the lumen either, right? So you have two equivalently good sort of a technique which will work very, very nicely should you have a lesion like this. You can see that. And remember guys, the lesion downstairs is very, very constrictive. I mean, it's a very short, it's a very small bowel compared to the bowel which you have above. So I need a 60 millimeter still, right? That is important. Thank you. So when you put a 60 here, the good way to put it is you go there and you turn and you push it inside and you turn. So it will automatically adjust itself down there, nice and clean. See this, automatically adjusted. Leave it, everything good, nothing there. So when I say nothing, basically that little nodule has also come out in that, and I can simply pass my staple. Now when I do this, see this, that ureter has gone far away. Okay, so when I do this, I have basically sort of done the surgery, guys, and all that is now remaining for me to do is basically just anastomose the segments, which I'm going to be doing any which ways. Yeah, so scissors. So now can you see this part which is remaining above the staple line here? I'm not going to just coagulate it. I'm going to be making sure that apart from the coagulation, my staple comes out through this now from here. Okay, just as a marker. Fine. So this much is done. Lot of things are done above. Oh ho, beautiful. You have such a highly mobile segment because you know we've mobilized it already, nice and clean. Here we go. go, come back. Just making sure if there is nothing there. Yeah. See this? Tiniest of the things, huh? But there's nothing, fortunately. So, just mobilizing like how we will always mobilize. Gentle. I think people have often not understood how gentle should gentle be, and believe me, it's got to be pretty gentle. There we go. There we go. Okay, good. Big region already mobilized. Fine. Come. This is where that part is. So, if is my hold here. It's a good hold there by Vismay. In fact, that is exactly how much we needed it to be held. That comes from experience only. I'll cut right through this. Scissor de do. Because there is a staple line there, I wanted to cut through that. Right through that. I'll cut right through the center. See that in 3, 2, 1. See that? You could hear that. That was my scissor cutting through the stapler. That noise. It makes that noise, huh? Typical. And here you go. I'll open. So this part which is opened will require also for me to use a Vicryl. That is number 1. Thank you. दे दो. Okay, do we have a non-tooth? Thank you. There comes. Now, often it does take people some time to get used to this maneuver. Can you see that? This maneuver requires some superb counter traction by Vismay, and only then it's possible. So you know, people have this beautiful charm of talking about leak rates, and they find it very interesting. People also have this charm of talking about doing or not doing colostomies for patients is concerned, and it's pretty engagingly amazing to understand one thing is that you probably don't really require a colostomy in this case. You actually don't. It's not a probable not. You actually don't require a colostomy. We'll show it to you. In fact, that's the reason why all these things are done live. I will also show you where you require a colostomy. So for people you know, often the ones who don't operate, especially the ones you know who have a lot of spare time available, they may be of the opinion that no, correct counseling and this and that. Guys, remember one thing, everybody passed out with the same degree that you passed out with, correct? So everybody is worried about their patients. Some just show it, some don't. Simple. Here we go. So straight enough suture, which may lead me to my scissors. And yep, scissors please. नीचे से डालो. So that's good. This is done. Now we'll be putting our circular stapler through below. Betadine and lignocaine jelly please. So let them apply betadine over this, let them put jelly over this. Thank you, that's enough. That's enough. So normally I need to understand one thing here from everyone. See, look at this. How that guy comes up. Okay, now once, see the uterus is also there, huh? Please note. See, I told you I'll come out through this window, through this plane. I'll come out through this plane, I told, because I want this part of the bowel to be coming in the disc. Yeah, that was the part which we coagulated, that corner, and that corner we want to come in the part of the disc. So no problem, just put it in, fit it nicely, gently, cleanly. All the three words are equally important. Again, I'll make it a little loose. I want to fit it nicely, gently and cleanly, and it has come nice, gentle and clean. And I open where it comes in the center. Beautiful, it comes in the center. So because of the bowel, no, yeah, thank you Vismay. So because the bowel is such, see that little bleeding na will cause the bleeding in the later part of the surgery. So whatever that little bleeding is, just coagulate it. Done. Yeah. Now great. Okay, छोड़ दे. This is not opening. ये खुल नहीं रहा है मेरा. My needle holder is not probably in its. So what is important from what Vismay is doing there? See this. छोड़ दे. It is important for us to note and to understand that before we snug it in, here it goes. So before you actually snug it in, I don't have the instrument which I normally use, which is the needle holder, but it's okay. काम चल जाएगा types. Yeah. So now before we snug it in, yeah, just make sure that the axis is correct. पाछड़ा Vismay. The axis is good. That is the noise through which it goes. And if you see, I will begin to pull and close gently. Close and closure has to be gentle. Now before I fire, I will look into the axis, which I think now is a good axis. Correct Vismay? It's a correctly placed axis. This is fine. No, this is fine. That's the posterior aspect. That's the ureter. Everything is fine. It's a very well nicely relaxed bowel, moving on beautifully. And because it is moving on beautifully on a relaxed bowel, I will fire. Firing is 10 seconds. As soon as I am done with these 10 seconds, done. So done with these 10 seconds, gently, see that the entire staple line comes out, which we have taken out now, and we will test the bowel with methylene blue. So can you look at this? See, this is that little tension on the bowel, yeah, on the mesentery. Just release it. रुक जाओ. See that these are your gentle steps of making sure that the patient will have an excellent post-op recovery. More release in the tension here. I have released off the tension significantly. This is now cute. Fine. अंदर डालो. I have not opened up the vagina, which is a very important part for me, because this is one of the best methods to prevent. I can sure see this, the thing, the path is clear, but let me just test it. So test, we're testing it with methylene blue, जोर से, and it's clean, fine. So there is no problem. The specimen will now be removed through the superficial 12mm ports under an endobag. Thank you so much guys for joining. I hope you all really enjoyed the demonstration, because this is something which we really wanted to go live with, get it to you. I hope she has a pregnancy naturally from here onwards, considering all what we have done for her. Thank you so much for watching, and bye bye.